Thank you, ladies and gentlemen. Stephen introduced himself as he's not an immunologist. I have to say that I'm not a neurologist. I'm just a pediatrician, just a pediatric endocrinologist, diabetologist who is interested in the process, what we can see with our patients with diabetes. So let me to start with this slide. Our old friend out of many other friends from India, Shaukat Chadikot was the first. He was the first time invited me being at this conference, and Banshi Shabu invited right now. Sadly, Shaukat Chadikot is not with us. It's a very bad situation. So, as a clinician, we know that there are a lot of things uh, uh, about the effect of diabetes on the central nervous system and the brain, but most of these findings are coming from adult studies. As you can see, hyperglycemia, hypoglycemia, vascular problems, hyperlipidemia, hypertension, so on. So there are a lot of effects and there are a lot of studies. But we are interested, of course, in pediatric patients. So let me mention one of the earliest pediatric studies which demonstrated that there could be seen some kind of intellectual problem, cognitive deficits, and most of these studies, early studies, concluded that repeated hypoglycemias have been as a cause of these alterations. And later trials showed that, specifically the DCCT trial, that okay, there is a little risk to cognition associated with hypoglycemia, although some kind of mild decline of psychomotor efficiency was observed, and probably these were associated with long-term metabolic controls. So recent evidences are interested to know what is the cognitive deficits and structural changes of the brain of our patients, and are there any risk factors? I would like to show this big study on neurocognitive performance. It's a meta-analysis, and this showed that although mild but significant effects were seen with regard to intellectual function, with regard visual spatial performance, or language problems, or motor speed, or attention condition. And some other studies show that, okay, there are some structural damage, although mild, but white matter is particularly vulnerable, and specifically the superior parietal lobule, hippocampus, and thalamus. And the specific imaging studies show that these mild but structural deteriorations can be observed. This is an interesting study which investigated the hypoglycemia effect on spatial memory, and the test is specific. Just to imagine if somebody is going into a room, try to memorize what particular details can be found, and after a while just recall what was found. And as you can see on the left panel of this slide, those kids with diabetes and who had 3 or more severe hypoglycemia provided the poorest result, as compared to non-hypoglycemic or non-diabetic kids. On the right side, it is interesting to know that the little kids aged less than 5 years produce the poorest result, and especially in those who had experienced hypoglycemia in this early age group. Again, this is an elegant study which prospectively followed and looked at what about the brain volume? How is it increasing? How was it increased over time? And showed that type 1 diabetes kids who had high A1C level, the gray matter volume increase was poorest or lowest as compared to medium or low A1C levels or non-diabetic controls. And hypo, the low glucose level, was associated with white matter poorer result. There are a lot of studies, or more and more studies, addressing this issue, especially what about the hypo and hyperglycemia? What about the relationship with gray matter, white matter? And many of them support that both of these conditions are bad for our kids. The onset of the disease is another interesting point. Just look at this slide. In kids whose diabetes onset was before the age of 7, as compared to those whose diabetes onset was over 7 years of age, cognitive deficiencies were possible to demonstrate it, and structural as well, with specific imaging techniques, were also significantly mild, but significant differences were observed. And this is another study showed that what is the white matter and what is the gray matter volume development. And as you can see that those kids whose diabetes onset was within the early ages, below the 4 or 5 years, there was a significant difference of the growth rate of growth matter and gray and white matter. It's interesting to know what is the outcome of early diagnosed diabetes. This interesting study showed that at the presentation situation with ketoacidosis, DKA, it's also important. Just look at this slide. The study followed up patients and looked at what is the fate, what is the consequence. And as you can see that in those cohort of patients with childhood onset diabetes, in those who are in the academic level, the influence of DKA at the onset was significant, was pronounced, and those who had moderate or severe DKA at presentation provided slight but poorer results as compared to those with mild or no DKA at presentation. Of course, scientists would like to know what is the background of these changes, and some specific techniques, MR spectroscopy, could have shown that, okay, there are some mediators within the central nervous system could be impaired, like glutamate and aspartate, and so on. And these are very interesting research topics for the future. Another aspect could be also relevant for our clinical practice. This study showed that, okay, if we look at the association of type 1 diabetes, childhood type 1 diabetes, with depression, anxiety, stress-related disorders, is there an influence? Okay, this study showed that patients with type 1 diabetes had clearly greater risk of depression, anxiety, and stress-related disorders. However, if the study looked at the family members of the patients, there were also mild but observable differences. So this could message that, okay, some kind of family aggregation, family factors are also behind these problems. So our main findings in children with type 1 diabetes is that, all right, neuroimaging studies show that there are structural impairments, deficits in neurocognitive functioning, and the most important risk factors are exposure to episodes of severe hypoglycemia, chronic hyperglycemia, clearly the early age of onset, and DKA at time of diagnosis. Okay, we would like to know what about the family history, what about this co-aggregation, and some other topics what I do not attach right now. There are some protective factors as well, as at least on the research level. What about sleeping, parental well-being, use of devices? These questions should be answered in the future. And of course, there are a lot of research on the pathophysiology mechanisms behind these risk factors. These are just putative theories. Early age of diabetes, hyperglycemia, DKA, hypoglycemia. How do these factors relate to the impairments? These are research topics. I wouldn't go into details. But from clinical point of view, this could be interesting that if poor glycemic control results in a subtle brain injury, reduced cognitive function could result in a problem with self-management, and again, a vicious circle could be observed, and poor glycemic control will be born again and again. So adherence to treatment or therapy would be impaired. And finally, just the light at the end of the tunnel. There is a pilot study to show that, okay, if we follow a meticulous glycemic control, this can improve with advanced technology, and in that case, we can prevent all of these mild but significant findings. In conclusions, so type 1 diabetes in children may associate with structural and cognitive impairment and early diabetes onset, DKA at presentation, and recurrent hypos and chronic hyperglycemias are the most important risk factors, and the potential link between cognition and impaired therapy adherence should be considered by clinicians, and alterations might be preventable or reversible with rigorous glucose control. And this slide shows that the famous chain bridge in Budapest, and behind the old Hungarian King's Castle. Thank you very much for your attention.